TF A type, rib unequal. Okay, Meghna, cardiomegaly, hyperinflated lung fields, rib crowding. Excellent. Okay, so you can see here ribs, right? So there are rib anomalies as well. So of course, something glaring at you is the tube, but do not forget to read complete X-ray. It's always from center to peripheral or from periphery to center. Do not forget to read the X-ray in toto. Okay, so the next question is, so what biochemical markers in amniotic fluid are used for prenatal diagnosis of this condition? Or maybe they are available. And what is their diagnostic sensitivity? This is any biochemical markers in amniotic fluid for TF, specifically for TF? So the next question is, what radiological finding is considered sufficient to diagnose long gap esophageal atresia? And let me show you third question as well. So we can, what is the reported incidence of associated anomalies in these patients? So I knew this is going to be a very simple, straightforward case. So I've included little different questions. Okay. So what happens? So any other guess? Okay. Let us go to the second question. So what radiological findings are considered as required to diagnose long gap esophageal atresia? Is this important to diagnose long gap esophageal atresia? Okay. Okay. So let us go to the answer. So these are the different types of esophageal atresia. I'm sure you all know about this. What is the most common? A, B, C, D, E, right? Most common type is type C, esophageal atresia with distal fistula. Correct? Are we on the same page? Yes. And the second most common type would be what? कौन बनेगा करोड़पति? A, B, D or E? Which one? The second common would be E, H type. Okay. Esophageal atresia, right? Yeah. So tell me, how do so clinically, how can we know that, how can we differentiate type A from type C just by looking at the X-ray? One finding that will tell us that this is type A and not type C. Okay. So gasless abdomen. Okay, that's the right word. Gasless abdomen will tell us this is type A esophageal atresia and there is no communication, right? Yes. So how do we suspect? Just a little theory that inability to pass NG tube more than 10 centimeter or tip of the NG tube not visible past upper thoracic region on plain film, gasless abdomen, excessive drooling, stridor, posturing during swallowing, chronic cough that is common with H-type fistula, cyanosis with feedings and feeding difficulties. So when these symptoms are there, then we need to suspect TEF. But for when it is concerned to newborns, it is inability to pass NG tube. The first three criteria are important with even excessive drooling. Okay. So analysis of amniotic fluid contains like GGT and alkaline phosphatase. These are the markers which will tell you that this is TF specific. So this can be analyzed and the sensitivity of these markers for TF is around 89.9%. Okay. And when the gap between the upper pouch and the lower pouch is more than or equal to 3 vertebra body, thoracic vertebral body, then it is called long gap esophageal atresia. Why is it important to know it is long gap or short gap? Because it will decide our surgical approach. Correct? If it is short gap esophageal atresia, then the baby will be posted for primary anastomosis, end-to-end anastomosis. When it is long gap, then gastrostomy and esophagostomy is done. Okay, so that's why it is important. And patients with esophageal atresia generally have associated anomalies, and the reported rates are 59% to 84.8%. Okay? Yeah. So now again, simple question. Now, this is a preterm infant born at 34 weeks of gestation. The baby is on CPAP. The requirements are FiO2 of 30% and pressures of 5. So the baby had distress, that's why the baby is put on CPAP. Now, there is no echo facility available in this setup. So when should pulse oximetry screening for be done in this baby for to rule out critical congenital heart disease? When should it be done? After 24 hours, before discharge, 25 hours, prior to discharge. What about CPAP? The baby is on CPAP. So can we do the screening in this patient? That's the catch. So what is the guideline now? If the baby is on respiratory support? Okay. So we'll talk about it later. And then there are few X-rays of a term baby who has failed a critical congenital heart disease screening, and then you have to tell me the diagnosis of that patient based on the X-ray findings. Okay, we'll go through this. So let us go through the current guideline, right? So this is the guideline. Ayushi Rathi. Okay. So the first question what we need to ask is whether the baby is on any respiratory support or not. Okay. So if the baby is not on any respiratory support, then more than 24 hours or pending discharge, whichever is later, pulse oximetry screening is done for critical congenital heart disease. Where should we put the probe? On right hand and one of the foot. So if the screen shows any site, if the saturations are less than 90%, it is called fail. The test is fail, and this baby needs evaluation, right? So if the saturations are more than 95% and the difference between pre and post ductal saturation is less than 3%, then it is passed. The test is passed and there is no repeat evaluation needed, and this baby goes for routine care. However, if the baby does not clearly fail or pass the test and has got saturations more than 95, the difference is not satisfying these two criteria, then we need to retest the baby after an hour. And if the findings persist, then the baby goes for evaluation. Okay. Now the next question was, this was a premature baby on respiratory support. So what is the new recommendation? That during the screening procedure, the newborn should either have no respiratory support or any respiratory support with FiO2 of 21%. Then only this test would be valid. Okay. So now this is again a term baby who has failed screening. What is the diagnosis? Look at the X-ray. What is the likely diagnosis? What is this sign called? Okay. Tough. Boot-shaped heart. Yes, excellent. It's a boot-shaped heart. It is Fallot's tetralogy. Okay, good. And there's a oligemia also. Apart from this, please look at the lung field as well. There's oligemia. Okay. Now, this particular baby failed screening test. What has happened here? TGA, agon end, agon string, agon side, agon end, agon string. Excellent. So you can see narrow hilum, agon side. This is an egg on string. Okay. So it's a TGA. Why does this happen? Because the enlarged right atrium and the left appendage being prominent. That gives a sign of egg. So it's a egg on string appearance. It is TGA. Excellent. Now this particular, it's a preterm baby, has sudden increase in FiO2 requirement. What is the diagnosis? Preterm with sudden FiO2 increase in FiO2 requirement. What is this? So it's a pulmonary edema, right? So if you see pulmonary edema on X-ray, then we need to see we need to check the baby for PDA. Of course, with the point of care so that we don't wait for these events to happen. Yeah. Okay. Now, what about this X-ray? Differentials. What is this X-ray? Can you see any lung parenchyma in this X-ray? HMD, TAPVC. What is it? It's a on X-ray. What do you feel? It is a lung problem or it's a heart problem? We're talking about the second X-ray. It's a lung problem or a heart problem. Okay. Can we outline? So you can see a clear border here. You can see a clear border here. So you can see clear border here. This one. So the entire chest is occupied by heart. Okay. So this is a correct. Somebody has mentioned, Aniket has written box-shaped heart. So it's a box-shaped heart. So box-shaped heart differentials are Epstein's. Any other differential with box-shaped heart or a big heart occupying chest? Any other differential? Sorry. Can pericardial effusion also appear like this? Dilated, excellent. Dilated cardiomyopathy, tamponade, Epstein's, perfect. Okay, so this is Epstein's. Okay. Now what about this X-ray? The first one. First X-ray. Okay. TAPVC, figure of 8, TAPVC, TAPVC. Excellent. Very good. Okay. Why is this figure of 8? Yeah, it's a supracardiac TAPVC. This is figure of 8 because this part, the right border is SVC, the left border is vertical vein, and the upper border is brachiocephalic vein. Okay, so that's why it is figure of 8. Correct? Yes. What about the second X-ray? This is also failed pulse ox screening test. The second X-ray. So you can see that this is all flooded lungs. The pulmonary parenchyma is not looking very good. It's failed pulse ox screening test. Difficult to diagnose. And picture looks like little RDS like picture. So which is seen in infracardiac TAPVC, obstructed TAPVC, right? So it is obstructed TAPVC. When you have a patient looks like an RDS, but it looks like RDS, you give surfactant. If it is a preterm baby and the baby does not respond, your PO2s are persistently low, then please um, think about TAPVC. And what would be echo finding in TAPVC? Bedside simple echo finding that will tell us that this could be TAPVC. What happens to flow across PFO? The flow across PFO would be right to left, right? That is a simple test. Yes, which will tell us that this could be TAPVC. Yes. Okay. That's simple. Now this is okay. So these are the questions. Which MRI scoring system is commonly used in asphyxiated neonates? So there is MRI scoring system. We do MRI scoring to prognosticate the baby's neurodevelopmental outcome. So which are the scoring system? Are you aware about the scoring system? One is written down only. The last question, Barkovich is one. Anything else? Okay, no problem. So how many MRI-based scoring systems exist for predicting outcomes in this video? I'll talk about it. And which scoring system is better? Okay. So these are the MRI sequences, the first, second, third. So which one is abnormal? The upper one is abnormal, the lower one is abnormal. Which one is abnormal? What do you feel? First, second, third. It's a T1 sequence, it's a T2 sequence, it's a flare sequence. Okay. So inverse sequence. So the difference between T1 and T2 is you can see the CSF, it is black. T2 CSF is white. Okay. And you can see that the white, ideally in ideal situation, it's gray matter is gray and white matter is white. So actually the brain looks like proper brain. However, because of the myelination problem here, the gray matter would appear like white and the white matter would appear gray. So this is T1 and exactly reverse happens in T2. Okay. And the flare sequence is the exactly like T2, but CSF is black. Okay. That is how you differentiate. Now this is a what you see here is posterior limb of internal capsule. So you can see some signal intensity, right? So this is normal. We should be able to see signal intensity in the posterior limb of internal capsule. So loss of this signal intensity would be abnormal. So here you cannot see the signal intensity, right? So this is abnormal. This is normal. This is normal. This is also normal. So these are normal MRI images, and this is abnormal MRI image. So you can see when the basal ganglia is affected, thalamus is affected, and there is loss of posterior limb of internal capsule. Okay. No, NICHD criteria is for staging HIE. Okay. We are talking about MRI. Okay, so what I'm trying to say is that whenever the MRI prognostication is done, okay, so we talk about how much gray matter is involved, white matter is involved, and predominantly it's called basal ganglia thalamus pattern, BGT pattern, and the internal capsule involvement. So cortex, BGT, and internal capsule involvement. Okay, so these are the areas we generally talk about. So these are the scoring systems which are available: Barkovich, Mathur, and Vic. So Barkovish is commonly used, but studies have shown that the weak is better than the Barkovish because this scoring system takes into consideration the cortex involvement, subcortex, so gray matter involvement, white matter involvement, basal ganglia involvement, cerebellar involvement, and also it considers if there is any intracranial bleed or sinus thrombosis. So this is the scoring system which is better. Okay, for the Barkowitz score, 0 is normal. 1 is when there is abnormal signal in basal ganglia or thalamus. 2 is when there is abnormal signal in cortex. 3 is abnormal signal in cortex and basal ganglia or thalamus. And 4 is everything is abnormal. Okay, so this is a scoring system. Okay. Now another case, this is very preterm 31 weeks. So these are the two babies born at 31 weeks of gestation, MCDA twins. There's history of hypothyroidism in mother. It was an elective LSS in view of deranged Doppler in twin 2. So twin 1 was weighed 1.2 kg, twin 2 1.095 kg. Both babies cried immediately after birth, had some distress, were put on delivery room CPAP. The first baby stayed in NICU for a month and the second baby stayed in NICU for 1.5 months. Okay. Now the question is, when should thyroid screening be performed in these babies? These are premature babies, 31 weeks, mother is hypothyroid. She is on Eltroxin, 34 weeks, 72 hours, 35 weeks, 36 weeks, 72 hours and repeated within 1 week after 72 hours. Okay, next question is, which test should be included in this screening? Is it only TSH, free T4, free T4 and TSH? Or TSH is abnormal, then after 72 hours. All. All means free T4 and TSH. Okay. TSH free T4, TSH free T4. Okay, good. And what would you say if what level is going to be abnormal for this particular preterm baby? Which level you're going to consider as abnormal? Okay, we'll talk about it. Okay, what is the recommended screening protocol in preterm babies? TSH above 40, that's what term? Any TSH above 40 in any baby, we should start treatment. That is perfect. So that does that mean that are we going to ignore the other value 11, 12 for a preterm baby? Okay. What is the treatment if screening is abnormal? Thyroxine. Dose levothyroxine 10 to 15 micrograms per kg. Okay. And what is the target once the treatment is initiated? What do you monitor? What is the target? When do you say there is a response to the treatment? Okay. Let us go through the protocol. There is a protocol for preterm babies. Okay. So thyroid screening should be done at 48 to 72 hours, either on filter paper. But these babies all are in NICU. You can do a venipuncture, or maybe you can just take a blood and send for the investigation. If the reports are normal, then repeat thyroid screening should be done at 2 to 4 weeks of gestation, 2 to 4 weeks of age. If it's a normal screen, then there is no need to repeat test. If the screen is abnormal, then we need to see. So yes, as you all are mentioning, it's free T4 and TSH. If the screen is abnormal, that is, if the TSH is normal or mildly elevated and free T4 is normal. So second screening should be done at 2 to 4 weeks. Any abnormality found, we need to investigate and treat the baby. Similarly, if there is low T4 and normal or low TSH. So when there is low T4 and normal or low TSH, what does this indicate? What kind of hypothyroidism is this? Or there is low T4 and high TSH. Yeah. So this is central. This is likely to be likely central, and this is primary hypothyroidism. Yeah, it is written there. So when it is primary hypothyroidism, we treat it. When it is low T4 and normal or low TSH, this could be sick thyroid syndrome also. Hence, we need to confirm this. If it normalizes in the repeat test, then we don't have to do anything. But if it is abnormal, again we need to treat. So are we clear about this? Okay. So important thing is do thyroid screening between 48 to 72 hours. Analyze. If the reports are normal, we repeat test at 2 to 4 weeks of age. Normal, then we do not have to repeat. If the reports are abnormal, then we have to treat the baby and investigate. Okay. And yes. So serum TSH of more than 10 milliunit per liter is elevated for preterm babies who have not reached term postnatal age, and a TSH of more than 6 milliunit per liter is the cutoff for these babies who have reached term postnatal age. Okay. The treatment is L-thyroxine, and when we start the treatment, our target is next 2 weeks. When we repeat the blood test, TSH and free T4, the free T4 should be more than 10 micrograms per deciliter. Okay, so T4 has to rise. That means the baby is showing response. So these babies were started on treatment. So the first baby's TSH was 21, and the second, okay, so second baby's TSH was 15. They were started on treatment. The TSH came down and T4 increased. Okay, here also the TSH. So here, because the baby had feed intolerance, we had stopped TSH in between. But again, we on repeat testing, the TSH had increased, and then we again restarted, and then the TSH is then again a normal level, and T4 is also increased. So these are the two babies. So it's very important to screen preterm babies. We all know that the term baby should be screened for thyroid, for hypothyroidism, but you do not miss out on the preterm babies. These are also equally important. Okay. Now the male infant was born at 38 weeks of gestation by spontaneous delivery. There was meconium strain amniotic fluid. CTG was abnormal. However, the tracings are not available. The baby was limp, required extensive resuscitation, and including chest compression. The 5-minute Apgar was 5. Baby was intubated in the labor room, transferred to the NICU, and is currently undergoing neurological monitoring. EEG was done and 3 hours tracing is this. Okay. So the question is, what is the complete diagnosis of this baby? Right? Complete diagnosis. What is the diagnosis of this baby? Do you want me to read the case again? Okay. Birth asphyxia. So we all agree this is perinatal asphyxia. And based on the EEG, HI stage 2, HI stage 3, MSLB asphyxia. Any other diagnosis? Grade 3 HI. Anyone else want to? Okay, asphyxia with seizure. What should be the next step in management? Moderately abnormal. Therapeutic hypothermia within 6 hours. AED. Therapeutic hypothermia. Whole body cooling. So neuroprotective intervention mean only therapeutic hypothermia or there is something else also? Therapeutic hypothermia is one of the neuroprotective intervention, but what is more important is stabilizing the baby. Development of supportive care. Okay. The baby needs to be euthermic, euglycemic, correct? Normotensive. Basic management should be done. The basic care is very, very important before even we consider therapeutic hypothermia in this particular patient. Okay? Yeah, correct. So hemodynamic monitoring and management. Okay, no hypothermia, no hypothermia, no hypo or hypoglycemia, no hypo or hypocalcemia. Okay, so that should be the first management. No hyper or hyperoxia and no hypo or hypocarbia. Okay, yes. And then hypothermia should be can be considered, but hypothermia, what is the window period to start hypothermia? Within 6 hours. Yeah, everyone is aware about that. Yes. So therapeutic hypothermia is one of the intervention for this kind of babies. Um, what is important is the basic management. Do not forget basic management. So this is amplitude integrated EEG with conventional EEG, right? So how does AEG help in prognosticating babies with asphyxia? Okay, we'll come back to this slide. But before that, just few words about AEG. So what is this first pattern of AEG? What is this? So left side is voltages, correct? So if I take a trace of the lower margin and the upper margin, okay, and if I just look at this graph, this appears like a spindle, correct? So it's a spindle. And the lower margin is above 5 and the upper margin is above 10. Correct. So it's a normal AEG with sleep wake cycle. Okay. Now what about this second graph? Yes, it's a continuous normal voltage. The second graph, where is the lower margin? Lower margin is below 5. Okay. And the upper margin is above 10. Okay. So lower margin is below 5, upper margin is above 10, and you cannot see any spindle here. Okay, so there is no sleep wake cycle. So this is discontinuous normal voltage. Perfect. Okay, what is happening here now? Look at the lower margin. Lower margin is below 5. Okay, upper margin is below 10, but above 5. And then there is something happening here, which is going above up to 25, maybe just crossing 25 also. Okay, Similarly, if you compare this graph, the lower margin, like the left graph, even the lower margin is here is also below 5. And the upper margin is around 5. Okay. But definitely more than 5. And then you can see similar lines which are touching and going beyond 25, right? So these are the amplitudes. These are the high amplitudes with some areas of lower amplitude. Okay, correct. So these are burst suppression, burst suppression, burst suppression. This is a burst suppression pattern. Okay, this is dense burst suppression. This is sparse burst suppression. Okay, now what about this EEG? So again, the low margin is below 5 and the upper margin is at or just above 5. Okay, so this is continuous low voltage EEG. Okay, and look at this EEG now. Both upper and lower margin is below 5. Okay, this is very low voltage EEG or flat trace, not a like guarded prognosis here. Okay, are we clear about this? Now, when we go back here, tell me what is happening in this segment. In this segment, the upper margin is definitely above 10 and there's no uniform lower margin. Something is happening, right? Something is happening. The entire line is getting lifted up and coming down, lifted up and coming down, lifted up and coming down. Similarly, this here, the same thing is happening. So these are convulsions, these are seizures. Okay, this part is seizure. And what is happening here? The lower margin is touching 5. Okay, and the upper margin is touching 10. Right? So this is a low voltage. Right? So we have conversions and low voltage EEG. Conversions and low voltage EEG. Okay? Are we clear about this? So here, one of the
Dr.
treatment.
Shilpa, can we
Yes. Oh, done.
can yeah.
Done. Okay, so this I'll just read out. Mild depression on day 1, normal background by day 7, associated with unfavorable outcome is predominant interburst interval more than 20 seconds on any day, burst suppression pattern on any day, and isoelectric tracing on any day, and mild depression after day 21. I think that's it. The last is still rare. Okay. Uh, I think for OSCE it is okay. That's it. Thank you. Thank you. Purna madam, done.
Thank you. Thank you so much, Dr. Shilpa, and thank you all of you for joining. We'll meet you all next Wednesday again. Good night.
Thank
Thank you, ma'am.